There's so many things that are making me very anxious right now. On the outside, I'm cool as a cucumber. But on the inside, Sarah is more tachycardic than this neonate. I assure you, this is my patient.
Oh my gosh, that's the same way as me. There's sweat dripping down my back as this is happening, but you gotta just like put it all aside and you just start going into nurse bear mode.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life.
Welcome back to the Rapid Response Nurse podcast. I am so excited about my guest today. You're going to love her because there's so much to learn. We are talking about a topic that is so far from my expertise, so I am just privileged to have an expert on the topic. So welcome to the podcast, Natalie.
Thank you so much. You're making me feel so loved and welcome right now.
I hope so. I'm glad you're here. So Natalie is a clinical coach in a pediatric cardiac intensive care unit and the host of the Chat with Nurse Nat podcast.
Yeah.
So before we dive in, what is a clinical coach? That sounds really cool, but what actually is that?
So on my specific unit, our goal is to support the staff when they're at their most vulnerable time. And it's usually within those first 2 years where they're just getting their feet wet. And so my job is to coach them in a tiered level. For the first 2 years, we do 5 shifts with every nurse, and it basically allows us to have one-on-one interactions where we go through a whole 12-hour shift, and I coach them through scenarios. I'm hands-on with them, kind of like their emotional, mental, whatever support they need at the time. But we do a lot of one-on-one teaching, and that it just fuels some really cool conversations around education.
That's awesome. So you're like the unit educator, except more elbow to elbow, less like competencies and annual certifications. You're like at the bedside with the nurse and their patient, teaching them how to do the challenging work that you guys do in the pediatric cardiac intensive care unit.
We are frontline buddies. We're partners in crime.
I like it.
Yeah. It's a wonderful job. I truly love it. And I've been doing this for about 12 years. Clinical coaching is a new role for me, but I love meeting new staff. I love seeing how anxious they get, but then you build into their confidence and you just see them grow. And it's a really cool job.
Sounds super rewarding. Okay.
Yeah.
So we have a case today that would make me so very anxious, but I'm sure this is like your bread and butter patient. Okay. So let's just dive into the case.
Okay.
Natalie, tell me, start from the beginning. What were your initial impressions when this patient arrived in the unit? Tell me a little backstory. What did you know so far? What did you see when this patient rolls in?
Okay, so today we're going to talk about all things neonate, all things baby. So maybe you could help me kind of talk about what does that triage look like from an ED rapid response side, because I don't have any experience in the ED. My initial reaction with any sort of baby that comes in is, what are the parents actually telling me? What's the story before this baby got here? And what you're going to find in these neonates is that story actually really matters. And it's because these symptoms that you're going to start seeing, especially in a neonate who's, 1 week old, 2 week old, those symptoms are going to help you kind of differentiate what's causing this sickness in this baby. And so what I'm thinking of is my initial reaction is the parents are telling me that this baby was very easily consoled when they got home from the hospital. Over the last couple of days, they started becoming very fussy. They're very inconsolable. We were taking bottles great. We were latching onto the mom's breast perfectly. Well, now we're having trouble taking bottles. We are not taking full bottles. We're actually vomiting after we take these bottles or we're breastfeeding. We're starting to have this increased work of breathing. It's actually giving me the chills talking about this because I've just experienced this patient. So these parents are just like, what is going on with my baby? And you just start seeing, their wheels turn. And so you're engaging with that family. What I will say from a triage standpoint is that this is crucial in even thinking about a cardiac component for these neonates. And we'll get into that pretty in depth in this conversation. But once this baby arrives to your unit, you're going to just look at them, right? You're going to assess them and you're going to see, what is the color of this baby? What does their work of breathing look like? Are they having that nasal flaring? Are they having those retractions in their ribs? I guess that's where I would start is what do they look like?
Yes. Okay. So I'm going to pause you right there and just interject from an ER nurse's perspective.
Yes.
We get a lot of parents that come in with newborns and they're new parents and they don't know what's normal and what's not. They're like, my baby won't stop crying. My baby's so fussy. They won't take the bottle. They're spitting up. All of those things are kind of normal newborn stuff, right? They do get fussy. They do spit up. Sometimes they don't want the bottle. We see a lot of that. And that's where you have to not just say okay, crying or fussy baby and take a seat. You have to assess the baby. So the baby's all wrapped up in their little car seat and all you see is just a little face in there. Oh no, we are taking the buckles off. We are taking the blankets off. We're going to look at this kid. I want to see their feet. I want to see their belly. I want to see their chest. I want to see their work. There's so much data I can gather when the kid is exposed. Leaving the kid in the little car seat carrier, maybe even on mommy's chest if they're in the little baby papoose, baby wearing contraptions. Yes. No, you got to get the kid out so you can see them. Additionally, how they interact with you when you're unbundling them is going to tell you so much about how this kid's doing. So yes, the parent story is important, but you have to pair that with your nursing assessment, your nursing judgment, a little bit of intuition, and kind of put them together to determine how sick is this kid. Okay, continue.
Couldn't agree more. That's a really good leeway into this next, what I'm about to say next. And so I think there are about 15 things that are happening right when you get this patient in the ED. You are trying to look at their cap refill. You're assessing their pulses. You're trying to figure out, where does this baby need access? Who's going to place the access? Where am I going to hook up this pulse ox? Where am I going to put this blood pressure cuff on this baby? You're going to be listening to their lungs as they're screaming at you. You're going to be listening to their heart. And you're like, I can't hear anything, honestly, as they're screaming. And so all of those signs that you're looking at before you start seeing the numbers on the screen is actually going to help you start building confidence into what you're really feeling, is that this baby is unwell and that this isn't just some sort of normal GI bug that this family is experiencing. And if I could say anything for this entire case study that we're going to talk about, is your hands on the baby's peripheral pulses and your blood pressure placement on these babies and your pulse ox placement on these babies will be crucial in the whole cardiogenic shock algorithm that we hope that you guys are going to go down if this is the true etiology.
Yeah. Okay, good. Let's circle back to that, because to be honest, I don't remember anyone teaching me specifically about where the pulse ox used to go and how to take the blood pressures. It was just get it where you can, right? You see vital signs. So yes, I definitely want to go into that. All right. So what did your ED do? What did they discover that made them want to send this baby to your unit in the pediatric ICU?
So every baby that comes in some sort of respiratory distress, they're going to get a chest x-ray pretty much right off the bat, right? At least in our emergency department, they do. They're going to hook that pulse ox up probably on their right hand, which we'll get into, their right hand, and they're going to take blood pressure on their legs and their upper body. They're going to listen to the heart tones and they're going to listen to the lungs. When they shoot that x-ray, you're probably going to see on that x-ray, those black spots of your lungs are going to be whited out. That's going to start leading you down a different path than a different etiology. On top of that, you're going to be getting IV access and you're going to be getting liver function tests. You're going to be getting a kidney panel. You're going to be getting your inflammatory markers, your CBC, all of the things that are going to lead you down. Is this patient in some sort of hypoperfusion state? Are their organs upset because of maybe poor cardiac output? Those signs right there are going to lead us to probably getting a cardiology consult pretty quickly, noticing that the lungs are wet. We're noticing an enlarged heart on the x-ray, and we're also seeing some sort of creatinine bump or ALT, AST bump. And most importantly, which is very difficult for even CICU nurses, is the heart sounds. And so you have this beautiful...
Girl, I wouldn't trust my own assessment with the neonatal heart tones. I'd be like, I hear it. It's in there, but I don't know that I could say there's a murmur or that I would not.
No.
Out of my expertise. You must have a really trained ear to be able to recognize a murmur in a little neonate.
Yeah, right. I pulled my providers in and we both have our stethoscopes on the heart. And I'm like, what do you hear? Are you hearing an extra beat? Because I'm hearing like 5 extra beats, so. But that is important. And the providers, the cardiology providers will have those ears that can hear the gallop that we're trying to recognize. The other part is that liver distension if we are having it. So it's that belly assessment. So you're really pushing on that belly, you're pushing on that right side. And this is something that we'll do as a bedside nurse in the CICU. And I'm not sure what the belly assessment looks like in the ED, but our providers are really, that's one of their first signs they do is they're actually checking that liver edge on that right side underneath the baby's ribs to see if the liver has expanded, which we can get into.
Okay. All right. So the ER found these things, I'm assuming, right? They found the liver is a little bit enlarged. The x-ray has some fluid on it. The heart seems larger than it should be. I think we're hearing a third sound, or maybe.
Question mark.
Yeah. How are the vital signs on this kid?
So vital signs, this kid's heart rate will probably be, for a neonate, we expect, 140, 160. This baby is 170, 190. You are putting that pulse ox on, and when you do get a good pleth, it might be reading 90%. When you check a temperature, you might actually be getting like a 36. They're not febrile. They're not 38 or degrees Celsius. So they might be 36. They're cooler. Their respirations, for a normal baby, 40 to 60. This baby's actually breathing closer to 70 to 80. So the vitals overall are telling you that this baby is in some sort of respiratory distress. We're tachycardic. And then to add in, well, are we compensated, or how unstable is this tachycardia? Well, you're going to hook up the blood pressure cuff to the upper extremities, the lower extremities, and then you're going to see, guess what? Probably some sort of hypotension, maybe, systolics 50s, low 60s, maybe your diastolics are around the 30 to 40 range, and then your MAPS might be, 30s.
Oh my gosh, that is, just hearing those vital signs is so scary for an adult nurse. That sounds really terrible. Okay. This patient is scaring the crap out of me. Let me just start by that, Natalie. Can we talk a little bit before we go into, why was this patient discharged from the hospital like this? How do you know where to take vital signs? Can you talk about just like basic anatomy of the neonate's flow of blood through the heart and like how things are different and how they change in the first little bit of life?
Yes. So just back to basic normal anatomy, you have blood returning from the upper part of your body, your brain, in an SVC, and then you have blood flowing from the lower half to your IVC. That's going to drain into your right atrium. It's going to go through a valve. It's going to go to your right ventricle, out to the pulmonary artery to your lungs. That is the whole right side of a baby's heart. In utero, the baby, all fetuses, have a patent ductus arteriosus, or we'll call it a PDA. This is a normal fetal artery that's going to connect your aorta, the left side of your heart, to the main lung artery, your pulmonary artery. And this duct in utero allows that blood to detour away from the lungs before birth. And where this is really important is that post-birth, that pathway, that fetal artery actually starts to close. And so this is a connection between your left side of the systemic side and the pulmonary side. And I don't know, it could be days, it could be, I've seen it, that PDA not close for, a couple weeks. And so where this is really important is that PDA, which I actually found this out yesterday, talking to the surgeon who's had eyes on what a PDA actually looks like in an open chest, it actually could be bigger than the aorta. So this tunnel.
Really?
Yes. And I had no idea. And so this PDA, if it's large enough over that first week of life, over that second week, it's going to start closing because of the pressure difference after birth, because you're going to start using your lungs as a baby. And so it's actually pulling, as it closes, it's pulling the aorta, that tissue, it can close it. And so it actually creates a shelf, and it creates a very, very narrowing in the aorta. This is what we would call an obstruction to systemic flow.
Okay.
Do you want me to pause there?
Yes, we'll pause there. Go ahead and Google it, guys, so you can get a visual. Ductus arteriosus, fetal, and then like what happens in the transition to the outside of the mommy circulation, how things change. Okay, so that would explain why this kid might have been doing just fine in the hospital.
Yes.
But now how many days post-delivery is this kiddo?
We'll say they're about, less than 2 weeks. They're in that 1 to 2 week range.
Okay, so this kid's like a week old, and now all of a sudden they're fussy, they're not taking bottles, they're spitting up, like they're very upset. This kid's unwell, but they were a week ago. Well, now they don't have that nice little PDA that's keeping things flowing for them, keeping them oxygenated, keeping them perfused. Okay, so with that in mind, how does that affect how or where you take vital signs on little tiny babies?
Great question. And probably one of the most important questions is where that PDA sits is, we call it preductal and postductal. So before the duct, this all is based off location and where the arteries are in our bodies. And so preductal means that it's before the duct. Why that's important is you want to know with that pulse ox or the blood pressure cuff, the right arm is going to be preductal on every baby. Postductal is after the duct. So you want to know, is there, once that duct closed, is there some sort of less flow going to the rest of the body? Well, you're going to determine that by their lower extremities or their legs. And so that's why this is so important, is you're going to hook up their pulse ox to their right hand, preductal. You're going to hook up a pulse ox and do a spot check postductal on their lowers. You might see a gradient or a difference. The right hand will be higher. The feet might be the one that's not picking up really great. You don't have that great pleth. The coloring on the feet might be different. Your cap refill is going to be different on the feet. For the blood pressure standpoint, preductal on that right arm might be a normal blood pressure for that baby. Might be totally okay. But when you cycle a cuff on their lowers, that's where you're going to notice that gradient of maybe 10, 15 points in that systolic number of your blood pressure.
Okay. So what is the number of concern? How many points different in millimeters of mercury and in oxygen saturation are we starting to be like, okay, we should be getting this kid at the pediatric ICU?
Great question. So we would say like a 15, in my practice, we would say about a 15-point difference, 10, 15-point difference in your systolic blood pressure. That also goes in with, do you even feel pulses in their feet? Are they a lot different than the uppers? Because I've had a baby whose coarc is, they're on duct watch in the ICU. So we're slowly watching their duct close. And I've seen their pulses stop picking up in their feet. And I can feel it. And it's like a couple hour span where you're like, wait a second, I don't feel them. Then you start going up their leg and you're like, I don't even feel, wait, the fem pulses are very different now. And so it's actually that progression, your assessment it is wild. The color, you just see the color change going up the baby's body as that duct starts to close.
Wow. Okay. Mm-hmm. So that occurrence probably happened to this kid at home.
Yes.
And the parents they weren't checking pulses on their kids' feet.
Right.
But now the symptoms are starting to pop up, right? The kid's fussy. They're not taking a bottle. They're spitting up. They're not perfusing well. So if you were to assess this kid, they come into your ER, we pulled the blankets off like we're supposed to, we're assessing them. Can you just clarify, what would you expect to find on a kid who has some sort of coarctation situation going on?
I would expect my pulses to be very poor in the feet. I would expect a lower blood pressure in the legs in comparison to the right arm. I would expect my kidney numbers, my liver numbers to be elevated. I would expect my x-ray to show pretty much left-sided heart failure is occurring, because that LV that's trying to pump out blood through the aortic valve, through the aorta, is starting to fail. And that is where you're getting all of these symptoms of the vomiting. The symptoms that we're seeing are all based off ventricular dysfunction, the feeding intolerances, because your gut's not getting perfused. And the first thing your blood is going to want to do is it's going to shun away from your gut, because that's, one of the most not vital organs. And that's why they're vomiting after the feeds. Their work of breathing is happening because that LV isn't pushing flow out through the aortic valve. It's actually backing up through the LA, going back to the lungs. And so you're having pulmonary congestion. It's just fluid. It's like they're kind of drowning in their own secretions at that of the blood flow. So that's where that increased work of breathing comes from. But the feeding intolerance on top of the increased work of breathing, on top of the poor pulses, which I can't emphasize enough in the lowers, and the blood pressure gradient difference between the right arm and the lowers is going to shoot off all sorts of red flags for this baby to get the cardiology consult and do they use, is it echo? Do you guys, an echocardiogram, or is it a different sort of heart ultrasound machine that you would use in the?
Oh, at this point, we're just going to call in the specialty team and be like, y'all decide what you want to do. We'll get you what you need. I'll grab supplies for you. But like, this is so out of our comfort zone, our realm of expertise. Like as soon as we're starting to think cardiogenic shock in a neonate, oh my gosh, I've become the support person. I am no longer the expert in this area. But I did want to just pause and go back for a second because to my ER nurses that are listening, we are so well trained to detect sepsis. Like sepsis is top of mind all the time. Everybody's got sepsis. Babies that come in got sepsis. Old people got sepsis. Everyone has sepsis until proven otherwise, right? And this kid is hypotensive, tachycardic, tachypnic. I would expect a super septic kid that's been throwing up to possibly have some poor perfusion to their extremities just because they're dry. So I think that all of us are probably going to go down the dehydration/infection pathway. But some of those things are just wasting time. And so I think that you pointed out some really good pathophys. It only takes a second to like rule this out. We're going to get blood pressures in upper and lower. We're going to check pulses upper and lower. We're going to check cap refill upper, lower, pulse ox upper, lower. And that's going to tell us a lot more that should make us say, this might not just be infection. This might be something going on with the heart. Because I'll be honest, I'm not going to hear the gallop. That's not going to be the red flag for me. I'm just going to listen and be like, I think I hear it ticking in there. But I can detect when the skin feels different, when the pulses feel different. I can look at the cap refill and see that it's different. All those things should be big red flags for the nurses caring for a baby who might have a congenital condition that was not caught. Maybe they didn't have prenatal care. Maybe it just wasn't caught in the ultrasound. The kid might have looked great going home from the hospital, and now they don't look so great. Okay, so I want to pause and like interject that in there. Okay.
Well, what you just said made me think of something. Now that you're giving me a little insight into your world and how your all's brains work, I wanted to add about the fluid boluses, because this could be something that would be huge for you guys in helping besides the assessment.
Yeah. Oh, everyone gets a bolus in the ER. You're hypotensive. You get a bolus. You get a bolus. You get a bolus. Everyone gets a bolus. Welcome to the ER. Bolus, blanket, turkey sandwich. Goodbye. That's like, that's our typical.
That's amazing.
I mean, I joke, but like everyone gets a turkey sandwich in the ER. Welcome to my ER. Here's your fluids. Here's your blankie. You feeling better? Here's a turkey sandwich. Discharge. But yeah, this obviously not neonates, but.
Oh my gosh, that just made me laugh so hard. So the fluid bolus is here. So you're talking about your fluid bolus. We do everything weight-based in kids, which I'm sure you do as well.
As do we, yeah.
And so you're going down this PALS shock algorithm when this baby's coming in. You brought up that it could be sepsis, it could be hypovolemic shock, cardiogenic shock obstruction. Those aren't really on your radar necessarily because you see the number 1 and number 2 kids coming in are sepsis and hypovolemic shock. Totally get it. I'm on board with you. Something that I challenge the nurses to do is when you're giving a fluid bolus, usually it's 15, 20 mLs per kilo of that fluid bolus. If you see that fluid bolus you're rapidly infusing is actually making your baby worse, red flag. If you're noticing that fluid you're pushing in is making your blood pressure drop more, is making you more tachycardic, is changing colors on you, whoa, we got we have a problem. And the physiology behind that is you're pushing fluid rapidly, a large amount into, someone the other day told me these babies' hearts, they're like cute strawberries. So imagine a little yeah, I saw one yesterday at work. It's incredible, but they're like cute little strawberries. So imagine pushing, let's say you have a 3 kilo baby, 20 per kilo, was that 60 mLs? So you're pushing 2 ounces of fluid rapidly in this baby. Their right side's expanding, trying to push blood through to their lungs. Their lungs are already wet from all the reasons we just talked about. That blood is trying to get back to the left side. And the ventricle is like, why am I seeing all of this? I can barely squeeze this blood out. And you just gave me triple the amount that I'm able to take. So what that is going to lead to is you're basically just stretching a massive rubber band that's not able to appropriately snap back and go through the aortic valve. When that function is so diminished on that left side, guess what's sitting right on the other side of your aortic valve? Your coronary arteries. They're not going to get blood flow. And guess what? Your heart's going to stop. And I've seen fluid boluses that when a patient is in true cardiogenic shock, I've seen those 20 per kilo fluid boluses actually have the heart stop. And that's when we have to start CPR.
Golly, you're getting my heart rate up. All right. That's a really good visual, though. Cute strawberries that are now over distended with a 20 cc per kg like fluid bolus, that's something to be thinking about, to keep it top of mind whenever we're considering fluid boluses. Like fluids are not benign. I think in adults we're like, oh yeah, just give them some fluids. Everyone feels better with a liter of fluids, but pediatrics, maybe not so much. A lot of the docs I work with actually do, for dehydrated kiddos, a 10 cc per kg bolus first, reassess, and then decide if you want to do another 10 cc per kg bolus. But right off the bat with the 20 cc per kg, unless we know for sure this is just like hypovolemia for whatever reason, just because there is that risk of over-distending the cute little strawberry. Okay, can you talk a little bit about how maybe we approach cardiogenic shock differently in a neonate versus, I don't know, a 10-year-old or an adult, let's say, that has cardiogenic shock?
Quick pause. I've got a question for you. Have you ever walked away from a resuscitation thinking, that went pretty well, but how can we be even better next time? Well, I hope you've asked that, because that's how we keep getting better and better as clinicians and as teams. Let me tell you about another great podcast that you need to check out. In the Heart of Care is produced by RQI Partners and hosted by Dr. Ash Panchal. You may remember him from episode 140. He's an emergency physician and educator who really understands what it takes to lead when the pressure's on. This show takes you inside the real work of building readiness, what systems and strategies actually hold up during critical events, and how teams train, communicate, and grow from both wins and missteps. You'll hear honest stories from the front lines, lessons from sim labs, and practical tools that can help your team perform better when it matters the most. So whether you're at the bedside, running education, or leading a team, there's something in every episode for you. In the Heart of Care is available now, wherever you get your podcast. Give it a listen. Now, back to the episode.
So that's a really good question. And I don't know, I would say that we're probably going to use the same drugs from a contractility standpoint. The drug that we won't use in a 10-year-old is prostaglandins. And so maybe you guys call it PGE or some other sort, but it's prostaglandins. And that the sole purpose of starting prostaglandins is to reopen the duct. And we want to know that if, basically not to rule out coarc, but if we're having some sort of hypoperfused state and we're having obstruction to the systemic flow, then we know in that neonatal period, we can try and open up that duct. That's going to allow a pathway for blood to shift to the right side of the heart, to the left side of the heart, and get blood out towards the body.
Which really just buys us time, right? This is not like a permanent solution. It just gets us time till we can fix this.
Correct. It just gives us time so we can fix this. And so the main goal is we start prostans. We see if the duct is open. So they'll come to us. The prostans will be ordered. You guys already got your IV access because you're amazing at that. And so we'll start prostans peripherally. We'll get central access on this baby to start all of our meds that are going to help support our heart from a squeeze standpoint. But the big thing about prostaglandins is we'll start at, a very low dose. Sometimes, though, we'll start at a very high dose. And the big thing about prostaglandins is it causes apnea. So it influences, I know, let's get deeper. It suppresses basically your respiratory center. And so think about this baby that's coming up to us, already in cardiogenic shock. We have to start this medication that's probably going to make them apneic. Well, we're going to have to intubate them, which brings in a whole other component of this story.
Whew, okay, so I have never personally given prostaglandin. I know that it's like the thing to do for a kid that, you got to keep the PDA open. Can you just talk about how does it come? How's it administered? What are like the interventions that you are doing to prepare for this medication administration? Like walk us through all the things that you would be coaching a bedside nurse on.
Yeah. So usually at our pharmacy, it'll get sent up. If we know a patient's in the ED and we get consulted, our docs are already putting in the orders. Pharmacy's already making that drug. It comes up in a syringe. We'll start at like a 0.01 mics per kilo per minute dose. And we can go all the way up to 0.1, which would be like a higher end dose. It's pretty rapid onset. It's a pretty quick offset. So once we start the med, hopefully within that first hour, first 1 to 2 hours, we're actually seeing that duct open. A lot of times we'll have the echo ultrasound probe on the heart, checking out the PDA, the size, to kind of verify that duct is actually opening.
That's wild. So you can like see it opening as you're administering the medication.
Mm-hmm.
That's cool.
It's pretty amazing. And so when we are about to, knowing the respiratory component that's already taking place with the pulmonary edema, the respiratory distress they're in, and then knowing we're about to give a medication that can create apnea, let's get all of our our intubation stuff ready. Sometimes they might come up intubated in the ED if they're sick enough, or they might just say like, we need to get them out the door, ICU, help us out. So this leads us into getting all of the prep work as the prostins is going, we're priming it through our syringe. We're hooking it up to the IV that we have. We're starting the drip. The echo probe is on the baby. We're acknowledging all this respiratory distress. The nurses are going to the Pyxis, the provider's saying, we need, fentanyl, ketamine, Vec or Rock, and we need to start preparing all the stuff for an intubation in prep for all the reasons that we just mentioned above.
Okay, so just to clarify, if you're giving prostaglandin, you're intubating. This is just, they go hand in hand? You would never give it without intubating?
Not always. Okay. So it depends on the severity of their duct close.
Okay.
It really depends on the severity of what they look like. So we have some babies that are just hanging out, chilling on low dose prostaglandins, and they're on nasal cannula. But when you have a very, very sick baby that's in cardiogenic shock, who's having poor oxygen delivery, then we're thinking intubation because of those reasons, on top of we're about to do a high dose prostins, and we need to support them from an oxygenation ventilation standpoint as well.
Okay, so that brings us to my next scary situation, intubating a neonate. It's scary enough just because of their size, right? But now we have cardiogenic shock and hypotension. Tell me why this is so dangerous. I mean, I know it's dangerous, but tell me why it's so dangerous to intubate this kid. And like, what are you doing to mitigate that risk of more hypotension? And you said apnea is a concern. Like, there's so many things that are making me very anxious right now. On the outside, I'm cool as a cucumber, but on the inside, Sarah is more tachycardic than this neonate. I assure you, this is my patient.
Oh my gosh, that's the same way as me. I mean, there's sweat dripping down my back as this is happening, but you gotta just like put it all aside and you just start going into, I don't know, like nurse bear mode. I don't even know what to call it, but yeah. So great question. So we are starting those prostins. We know that their heart function is having trouble. So as it's pretty much like 5 different tasks are happening at the same time.
Oh yeah. This is a team sport right here.
Team up, bring in the sidelines, bring in the moms and dads. Let's get everyone on board. And so the patient is probably going to be started on an epinephrine and calcium drip. So we're going to be supporting it from a maintenance drip to help the squeeze of the heart. Okay. And so as we're setting up the calcium epi drip, because we have access, because we got the first stick ever for central access, our prostaglandins are already running. We're lining up our fentanyl, our ketamine, our Vec. Then we have all of our emergency meds to support the cardiac arrest that could happen during intubation.
What blood pressure would you feel comfortable with proceeding with RSI? Because I know for adults, my comfort zone, but I don't know for a neonate. How low is too low to give all your RSI drugs?
Great question. We usually focus a lot on the systols, but the MAPs. So we want to know, the MAPs. So we want to make sure that the kidneys are getting perfused, the brain is getting perfused. And so if we start noticing, I would say MAPs, and I've seen them as low as diastolics in the 20s, MAPs in the 30 range. And so we're going to be assessing from that standpoint. I would say, 50s over 30s, we're getting a little bit uncomfortable. If our heart rate, really what we're trying to also look at is our heart rate. How well are we compensating? Did we just get super tachycardic and our blood pressure is not maintaining? Well, we're going to help support that.
Okay.
Great question. I hope I answered it.
You did. Because in the adult world, we talk about, resuscitate before you intubate. Just shoving a tube down somebody doesn't fix anything. You have to optimize them before you intubate them because all the RSI drugs, supposed to change your positive pressure in the chest, all that's going to drop your cardiac function. And so we just want to make sure that they are optimized before we go, doing all the things that we do to intubate. All right. So you're okay with 50s over 30, as you said.
We're getting uncomfortable there. So we'll probably have, we call an epi spritzer. So it's like a 10th of a co-dose drug.
We have those in the adult world too. Yeah. Okay.
So we have epinephrine already drawn up. We have calcium drawn up. And then sometimes we'll even have atropine to support that bradycardia that could, the impending bradycardia from the ischemia, right? And so a lot of times we will give the patient an epi spritzer prior to intubating. Sometimes we'll give them that. This patient probably is already getting calcium boluses on our unit from the 50s over 30s. So ideally, we'd like this patient to be 70s over 30s, 70s over 40s.
Okay.
So once we start hitting that 50s range, low 60 range, we're going to start prepping all these RSI drugs. But pre-intubation, yes, epi, calcium, maybe some bicarb to correct that acidosis that's occurring. Where the four key points I'll point out with why a patient would decompensate during intubation process is the stress of the intubation. So transiently, you're going to be in a sympathetic nervous system response. You're going to be in that fight or flight. The body is. You're going to increase the heart rate.
So am I as a nurse. I also am going to be sympathetic zone.
Absolutely. So you're increasing the heart rate, you're increasing the blood pressure. You're making your heart that's already unhappy work harder to consume more oxygen to get through this period. So you basically just are demanding more of something that you don't have enough supply of.
Okay.
You're also switching your system from going to a negative pressure system, airway pressure system. So we're spontaneously breathing, that's negative, to a positive airway pressure system. So we're actually forcing pressure into our chest cavity. Well, what does that do? It actually makes all of that blood volume that wants to return to the right side of the heart not want to go there. So not alone are we also causing stress on the ventricle, we also don't have enough volume in our ventricle to actually squeeze out. Lastly, giving sedatives, what are we going to do to our blood pressure? We're systemically vasodilating them with sedatives. Mm-hmm. So we're really just checking all the boxes up to create a cardiac arrest to get to the point to fix the baby.
Yes. Okay. All right. So this is a whole team to optimize this kid before you intubate.
Yeah.
Can you talk about, because again, we all memorize this in nursing school so we can pass the test, but I think most of us have not heard of or seen a patient with coarctation of the aorta. What does that actually mean? Can you just give us a visual image of what's happening? What's the aorta look like? What do we do about that, both medication-wise and surgically?
So I love this question because the baby that got air cared to us yesterday with actually the same diagnosis, they brought up the CT and they showed us exactly where the pinching of the PDA closing, it's actually pinching where the aorta is. And it looks like a kinked hose is how I can describe it. And so your aorta, I think it kind of looks like a candy cane in that shape. And so just think about that candy cane shape. It is kinked, cracked. That hose is so narrowed that basically, I don't even know if red blood cells are getting through that narrowing. That is what coarctation is. It's a narrowing in your aorta, usually by where that PDA is closing, but it could be along anywhere in your aorta. And that is why the imaging that we'll get before surgery would be a CT to show exactly where that narrowing is occurring, how far it's occurring. And then it would be a whole conference on, does this baby, one, they need a surgical operation to either ligate the PDA, take the PDA out and balloon or open up, stent that aorta. So it could require an open heart surgery if they needed more access to the aorta. But sometimes if we know exactly where the spot is on the CT, we can actually go in through the left side of the rib cage and we can actually go in that way and kind of the surgeons will, snip, resuture and take that out.
Really? Okay. So you basically remove the narrowed spot and just reconnect the aorta where it's wider. And then the baby has good outflow coming out of the left side of the heart.
Sounds like a quick fix, right?
Yeah, easy peasy. Yeah, that's a little arts and crafts, snip, resew, we're good to go. Okay, very, very cool. All right, so this kid is going to be intubated, started on prostaglandins to buy us time so we can optimize them and prepare for some sort of surgical intervention.
Correct.
As far as managing the heart failure itself, what are we doing to optimize the heart failure side? Do you guys do inodilators or are you just doing epinephrine? I know the problem is the coarctation. That's the issue that has to be fixed. But in the meantime, how are you guys optimizing cardiac function from a preload, afterload, contractility perspective?
So it's a great question. We'll attack it in a couple different ways. For cardiogenic shock, I'm going to think about 3 buckets. I'm going to think about it from a preload standpoint. Do we have a safe amount or the correct amount of blood flow returning to the right side of the heart so we actually can squeeze volume out to perfuse our brain, our heart, and our organs? We did that with, those 5 per kilo boluses to help kind of fill our tank up. The next bucket we're going to look at is the squeeze of the heart. And sometimes maybe the most important is how well are we actually, what's our ejection fraction? How much with each pump, how much blood flow is leaving the body with each heartbeat? And so that squeeze is very important. we'll do drugs like epinephrine to help support the contractility because it's a beta 1 drug that's going to help increase your heart rate, but also the strength of the squeeze of the heart muscle. The second drug is babies love calcium. And so calcium is actually, if we're going to be supplementing with a calcium chloride drip, we're going to increase the amount of calcium in the heart muscle that's going to help with the contractility and the squeeze to make sure that we're adequately perfusing the rest of our body. And the last bucket we'll talk about is afterload. How can we decrease the amount of pressure that the left ventricle is having to push against? And so drugs that we would start would be like a milrinone drip. In order to help with our lung component, we would start gentle diuresis. They might get a few doses of, Lasix or something like that to see if we can actually pull fluid off their lungs to help oxygenate and ventilate better, which is only going to help our left-sided heart failure.
Gotcha. Sounds very, very complicated. I know at least in the adult world, I love milrinone, but one, it takes forever to kick in. And two, it's going to affect blood pressure. And so before we go start a milrinone drip, I want to make sure that I've optimized blood pressure with other means before I add that dilator to the patient.
Absolutely. Absolutely.
Okay. So as far as wrapping it all up, how did this kiddo do? And then I want to go into just a review. What are the key signs that we're looking for a kid that we're thinking about a ductal dependent issue?
So this kid was stabilized in our CICU. We stabilized them with, filling the ventricles up, giving those small boluses when needed, making sure that if they needed blood, that was the volume that we were using to help support their ventricles. We were supporting their contractility with the epinephrine and the calcium. We were helping that afterload by starting that prostaglandins drug to open up that duct to see if it decreased that constriction of the aorta. We are looking at their end organ perfusion with their lab work from their liver and their kidneys. If that creatinine is continuing to bump after we've started the prostaglandins, that's another discussion of, is there something else going on? Which would lead us, do we need more imaging? If we open this duct up and we thought we fixed the constriction, but our kidney numbers, our liver numbers, our perfusion, our pulses are still not getting better, we might need to get a CT scan that's going to actually show us all the anatomies of the heart, which is what we ended up doing on this baby, which also showed us that we could actually just do a left thoracotomy attempt. So they scheduled this baby on for the next morning. They went in through the left ribs and they were able to do the arts and crafts that you were talking about before. This baby did great.
Really, really expensive and highly precise arts and crafts. Yes. Gosh, that is so cool. Okay, so now let's talk about, you are maybe an ER nurse, maybe just a friend, your friend has a new baby and they call you is this normal? I've actually had friends take videos of their kids breathing and send it to me is this normal? Should I be worried about this? So what are the clinical pearls that should make you say, maybe this is not just the kid needs more bottles. Maybe this is something else going on that I need to raise the red flags about and be cautious in how I'm delivering fluid boluses.
I would say that the coloring in their feet in comparison to the coloring in their upper body, if we're talking about parents, it's a little bit different of, feeling pulse and things like that. But if you're asking your nursing friend, what do the pulses feel like in the lower extremities? And they are very easy to find. They should be very easy to find. They should be bounding. They should be beautiful. You should have nice pink baby toes. If you're seeing that dusky color of those baby toes, if you're noticing whoa, I'm not feeling any beats on their little fat pads on their feet or behind their little ankle bone, those are all things that you're going to be this is weird. All babies should have pink toes that match their upper body, pink fingers. All babies should have a bounding pulse in their feet that matches the bounding pulses in their hands. Those simple assessment skills will change the way we're thinking about how to care for this baby.
Okay, that's good. So this podcast, we talked about coarctation of the aorta, but there's a bunch of other congenital heart disease diagnoses, way more than I could ever remember. Do you have an easy framework for just kind of categorizing the different congenital heart lesions and then how maybe we approach them differently?
Honestly, I reflected on this question for a while because I know that providers, intensivists, they have a very specific framework that they're using in their mind. And I don't want to get too much in the roots and the weeds for nurses because I don't necessarily have this standard algorithm that I use. What I think about is is the patient in some sort of obstruction to their systemic flow? Meaning, are they presenting in a shock presentation? Do they have an altered oxygen delivery to their tissues? That's one kind of category, think about it. Or is there an obstruction to their pulmonary flow? Meaning they would present very, very blue and they would present very, very hypoxic.
Okay.
The last category would be mixing lesions, which are your VSDs, your ASDs. So is the blood shunting? Are there openings or holes in the heart where the blood is shunting from the left side to the right side? That could create a mixing, call it purple blood versus just straight blue blood. Those would be the three big categories that I would focus on or think about. And if you know if it's an obstruction systemically, you're going to treat that differently than pulmonary obstruction. And then you're going to treat those holes, the mixing lesions, differently. That is as simple as I could help with the...
That's exactly what I was looking for, Natalie. You nailed it. That's exactly what I wanted to see. So are we looking at perfusion issues? Are we looking at oxygenation issues? What was the third one again?
All the little holes, yeah. Cheese holes.
Yeah. Okay. Oh my gosh. All of them scare me. All right, Natalie, this has been so valuable. Is there anything else that you want my audience to know? Because not all of them are peds nurses, but a lot of them are ER nurses who get peds patients. Any final pearls, takeaways, don't forget this, stuff that your pediatric cardiac ICU nurse coach would want you to know?
I would say just understand the transition from in utero to birth and just think of those three letters. PDA. Just think about it. If you can think of just PDA and you don't even know where it's located or what that even means, just have those three letters in your mind and then Google it or use your resources at your institute and be like, why did that nurse say PDA to me on a neonate? Just those three letters. And I think that would really help just at least start the conversation of, is this something that's not sepsis? Is this something that's not a GI bug? Is it something that's not hypovolemic shock?
Right. Okay. No, that's good. That is good stuff. I wish you could have told me that when I was starting the ER, because honestly, all of that stuff I learned in my pediatric lectures that I memorized to pass the test, I just forgot it all. So it took time for me to go back and relearn it. This has been so valuable. I'm sure my listeners have just loved learning from you. You really explain things very clearly. I'm sure they would want to find your podcast. Can you just tell them where they can find you? And I will also put the links in the show notes.
Oh, thank you so much. Sarah, you truly just are able to have such a fun conversation with someone that, we've met one time before this, but you just make someone feel so welcomed. And it speaks to who you are, the way you are, and how you can just support nurses in this way. And it's truly amazing. And thank you so much for having me. The podcast that I've been working on for it's going on a year and a half. So I'm very new into the world, but it's Chat with Nurse Nat. And you can find it on Spotify or Apple Podcasts. I also have an Instagram account, chatwithnat_RN. I'm working on amping it up, getting excited about it. And you are a great role model for that. So thanks for being my hype woman in this whole journey.
Yeah, girl. And they're the Nursing Education Podcast. Welcome to the club. It's a very small niche in nursing. So I'm so glad to have found you because we got to support each other, man. This is important work. What a gift. Let's say I'm a nurse that has never cared for a pediatric patient, but I know I could get them. I work in a rural ER. They could be coming my way. What a gift to have the valuable resource of a pediatric cardiac ICU nurse coach in my earbuds. So yes, check out her podcast, guys. It really is. It's free. I just love nursing podcasts. It's such a great resource. I originally started mine just thinking it would help the nurses at my local hospital. And then I realized, oh, wait, there's nurses across the globe that also want to learn about caring for emergencies. I get to support nurses I've never even met before. How cool is that? So yeah, welcome to the club, Natalie. So glad to have you.
Thank
You guys definitely check out our podcast. The link's in the show notes. Natalie, thank you again for your time today. This was excellent. I learned new things as well. Thank you so much for sharing your expertise with my nursing world and also in your podcast as well. You have a great rest of your day.
Thank you, Sarah. You too.
Thank you.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.